Hello, my name is Hope Frost and I'm from SBK Healthcare. Welcome to the recording of Introduction to Lifestyle Medicine for GP and Practice Nurses webinar, with thanks to our collaborator and supporter, the British Society of Lifestyle Medicine. You will hear Dr. Alex Maxwell and Dr. Fraser Quin guide you through the realities of incorporating lifestyle medicine into your clinical practice and showcase the outcomes of adopting a more positive, holistic approach to chronic disease management. For further free content, please visit www.sbk-healthcare.co.uk. Thank you and enjoy.
So as Hope said, my name's Fraser Quin. I'm the we call it Executive Director. It's effectively Chief Executive Officer of BSLM, and my role in the organisation has been and is to take the charity from what was a volunteer-led organisation to a professionally run charity with a permanent headquarters and headquarters staff team. So we've been on a very exciting journey over the last few years, and I'll just talk about our trajectory in a second. I'm joined by Dr. Alex Maxwell, who is the president of the British Society of Lifestyle Medicine. He's also a GP, a school doctor, an entrepreneur as well. So he'll no doubt introduce himself further in a second. But could we go to the next slide, please, Alex? I want to just declare some further interests beyond BSLM, but to do so really to explain where lifestyle medicine is evolving. So the British Society of Lifestyle Medicine is the biggest lifestyle medicine society in Europe. And in 2019, we started the European Lifestyle Medicine Council to support the development of lifestyle medicine in other countries throughout that region. And in 2023, we were the organisation responsible for starting the World Lifestyle Medicine Organisation, with then 22 other members from around the world, but now 48 members represented from all continents. So lifestyle medicine is very much a global movement. And it's really important that we have an overarching body in the World Lifestyle Medicine Organization so that the term lifestyle medicine, the definition and how it's practiced is actually protected. That's incredibly important because there are many organizations around the world that call themselves lifestyle medicine, but are not evidence-based as we are and as the mainstream lifestyle medicine movement is. A further role of the World Lifestyle Medicine Organization is to be the accreditor for global education, again, to ensure that when we talk about lifestyle medicine, we're all talking about the same thing. And I'm extremely proud to say that BSLM's core accreditation, which is our flagship course in lifestyle medicine, was the first course to be accredited by the World Lifestyle Medicine by international experts. So we're very proud of that. But it is therefore a global and very much a growing movement, which is now very much mainstream medicine. Next slide, please. I'm going to say just a little bit about the trajectory of BSLM, just as an introduction, so you understand who we are, because there are some interesting points here in our lifespan. So it started in 2016 by 3 members, 2 GPs and a urologist, surgeon, and we now have over 3,000 members. So actually, we've experienced significant growth over the last few years, and in particular in the last 3 or 4 years. Lifestyle medicine is very much becoming accepted as mainstream medicine. And I think one of the tipping points was at our 2022 conference when the then RCGP president, oh gosh, I've forgotten his name, Martin, sorry, I've gone completely blank. The former president of the RCGP said that lifestyle medicine was the future of general practice. And that actually was a tipping point and allowed BSLM access to organisations and individuals at government and within NHS to really talk about lifestyle medicine at an elevated level and at a level on a par with other specialties within the National Health Service. Our conference last year in Newcastle was the best attended conference ever, and we had 1,200 people on site, and we had a further 450 people joining online. So altogether, a very impressive growth rate from 2016, where we had 3 members, through to a conference of of 1,600 people in attendance. Next year, we're in Brighton on the south coast at the Brighton Pavilion with our gala dinner on the pier, which should be very exciting. So you're all welcome to join us at that event. It would be fantastic to see some of you. And at the end of this presentation, there's a discount code for membership if you wish to join, a 50% discount code. But one of the key things I want to talk about just before I hand over to Alex, who's going to discuss what is lifestyle medicine and how it is applicable within practice currently, is education. So in 2023, BSLM launched its core accreditation in education, and it's been called the flagship, the gold standard lifestyle medicine education throughout the world. And that's not me saying that, although I'm more than happy to repeat it as often as I can. But it's been recognized as the gold standard, and it is now being adopted throughout the world, which I'll talk about a little bit later. But education is one of the key areas that BSLM are involved in, as well as advocating politically on behalf of lifestyle medicine at all levels, regionally and nationally. NHS, or what was NHS, will soon be Department of Health and Care, and direct to government as well. We also deliver services to members. We support members in developing their own lifestyle medicine practice, be it private or be it within the current health systems. And we very much want to encourage lifestyle medicine practice in the public sector, not the private sector, although we absolutely acknowledge that some people want to practice privately, and that's no problem. We'll support people with lifestyle medicine at whatever level they wish to practice. So education is a fundamental part of what we do because it enables GPs, nurses, physiotherapists, dietitians to understand the principles of lifestyle medicine. And Alex is going to go into significant detail about that in a second. But behavior change in lifestyle medicine can only be supported by education, and the correct education, an education that is genuinely lifestyle medicine and not alternatives. We are absolutely evidence and science based, and we are absolutely I was about to say we're zealots when it comes to that. We're not quite zealots because we need to be careful about extreme terminology in the current international political arena. But we are very focused on evidence and science, and that underpins everything we do in terms of both the education, the research, the advocacy, and the practice of our members. So next slide, please, Alex. So the education of BSLM is a fundamental part, as I said. So the core accreditation is the flagship project, and that is 100 hours of learning to become accredited by BSLM in lifestyle medicine. It's a postgraduate qualification, and it's open to all healthcare practitioners. Obviously, there are different levels of assessment, which I'll talk about in a second, depending on actually where within the health system that you come from. We have our annual conference, and again, that's Brighton this year. And please do look us up on the website. There's a link later on, several times actually in the presentation. So please do look us up. We have about 80 speakers, both international and national, and some very big names in there. So previously we've had Michael Marmot, Tim Spector, so on and so on. There's too many to list, but a very significant international conference. And then we developed a learning academy in 2021 based on a learning management system provided by D2L, which is university grade learning management system, to host all of our CPD and as well as the core accreditation. Next slide, please, Alex. We also run webinars. So to date, we have run over 1,700 hours of webinars for our members, and they're free to members. We run 2 a month, and they're typically on a topic, a very specific topic around lifestyle medicine. It could be around sleep patterns, it could be around pain, nutrition. We cover all bases and try and ensure that we are up to date with what is important to people at a given the membership, obviously at a given time. So lots of webinars recently around menopause, women's health, around cancer, and obviously weight loss and obesity and so on. CPD, we have bite-sized CPD 1 and 2 hour courses which are very easy to dip in and out of. And then obviously the larger in-depth courses such as the gut microbiome and pain management courses. So gut microbiome is a 12-hour CPD course. Pain management is 8 hours, written by Deepak Ravindran, who is an internationally renowned pain specialist. And to date, we have delivered over 60,000 hours of CPD. So we have a significant CPD offering and are the main deliverer of CPD in the lifestyle medicine arena. The link there, Learning Academy, that's a live link that when you receive copies of the slides, you can link directly to see exactly what it is we're doing around education in at BSLM. Next slide, please. Just a quick word about the core accreditation. So again, that's the flagship BSLM offering in education. It's a spiral curriculum, similar to university. You start with the attitudes and foundations of lifestyle medicine. You don't progress to the next stage until you've passed the assessment on that. So there are 3 assessments, as you can see there. Knowledge in terms of the 6 pillars of lifestyle medicine, and Alex is going to go into these in much more detail. And then importantly, how to put all of this into practice. So what does it mean in terms of talking to patients and talking to groups and using lifestyle medicine behavioral change tools to actually implement lifestyle medicine? The important thing from this course is that it's very flexible. So you can start at any time of the year. And it's very much open-ended as to how long you take to do it. Most people take about 12 months to do this course. It has been done in 3 months by a very dedicated professional. But equally, people take between 12 and 14 months typically to do this. And once people get to 12 months, we do start to prod them and see if there's any help we can offer. We set up learning groups. So there's a peer support element to this. You can meet people who are also learning about lifestyle medicine at your leisure. And importantly, you can tailor this to your own particular interest. So if you're a nurse, for example, who is the lead on type 2 diabetes, all of the assessments can be tailored to your interests. So as long as you're covering the learning outcomes, there's very clear guidance on that, you can talk about how you interpret lifestyle medicine in type 2 diabetes and the lifestyle medicine tools that can be used to help put that disease into remission or to treat it and get people's HbA1c under control and so on. So it's a very flexible course. Next slide, please. And finally, from me, I talked about the World Lifestyle Medicine movement and the importance of that in helping to define what lifestyle medicine is. But I just wanted to highlight the expansion of BSLM's education around the world. Which I think is fantastic from our point of view, obviously, but great from the movement's perspective, so that we are all talking about lifestyle medicine in the same context. What we're doing is we're partnering with organizations, as you see here, to develop our core accreditation to be relevant in their regions. So the principles are the same, the 6 pillars are the same, but regional interpretation is different. So lifestyle medicine delivery in Australia amongst Aboriginal communities, for example, will be different to our delivery of lifestyle medicine in the Western world and certainly in the UK. So a very much an important growing mainstream movement. So on that note, I'm going to hand over to Alex now, who's actually going to tell you what lifestyle medicine is. So thanks, Alex.
Thank you, Fraser. Hello, everyone. Right, I've got the reins, so I can click through as I need. I hope you're all okay. So yeah, my name's Alex, Dr. Maxwell. I am the president of the BSLM. Really pleased to be here. Thank you to SBK. And it's great that you're here to have a think about lifestyle medicine. I'm sure you're all keen to get cracking, so I won't dilly-dally for too long, but this is what I was hoping to cover. Now, I've only got about 25 minutes, 30 minutes to go through what is a lot, and therefore is a bit of a whistle-stop tour. And I can't go into too much detail about certain areas, but if you have got particular questions that you think you'd like me to spend a bit more time on, and believe me, I'd love to. Most of these slides I could waffle on for an hour. Then ask the question, put it in the Q&A, and we can address it in more detail later. Because I'm sure I won't cover everything as much as you'd like. So yeah, lifestyle medicine, a particular touch on health inequalities, how we can integrate it into our practice, and then any questions that you have. So this is me, a particular interest. I'm a GP, particular interest in child and adolescent health, lifestyle medicine. And as Fraser said, I am a director of a health business as well. All right, so what is lifestyle medicine? Well, for those of you who like reading, it's this one, the evidence-based clinical care. So it is evidence-based, as Fraser has emphasised. It is clinical care, so it's not public health, or the more broad population health-based endeavours. We support them. It also supports behaviour change, and what we mean by that is having skills in the psychology of health behaviour change. It's person-centred, of course, as all good medicine should be. And then we improve those 6 pillars. That's mental well-being, social connection, healthy eating, physical activity, sleep, and the minimization of harmful substances and behaviors. So in a sentence, it's an evidence-based approach to improve the health and well-being directly of individuals and indirectly of society. And it's not looking to replace current medical practice, but to support it and improve it. For the more visual of us, which I think is probably me, it has 3 principles, which are an awareness of, an acknowledgement that we need to support and impact as we can, and at least be aware of the upstream determinants of health and disease. So these determinants are people's housing situation, the environment that they're in, their financial situation, all of those. The second principle is an understanding of the psychology of health behavior change. How many of us have, and this is absolutely myself included, many times over the years, given people health advice, as they're walking out, oh, eat more broccoli, you should eat better, as they're going out. But actually, was that the right way for them at that person? Was that truly person-centered? And did that appreciate those skills in how one can actually change someone's behavior? So that's principle 2. And then principle 3 is the pillars of lifestyle medicine that I have outlined already, and I'll go into a bit more detail later. Principle 1, 2, 3. And it's in that order, because we know that the social determinants, the upstream determinants, are very, very important, and we must always remember that. So speaking a little bit more and contextualizing the importance of the upstream determinants, modern medicine often focuses more on the hard outcomes. So you can see there, cancers, diabetes, cardiovascular disease, etc. And then the markers of those risk factors, BMI, blood pressure, lipids, sugars, etc. We focus more on them. But actually, what are the causes of those? What are the factors that are impacting people's health that are less in their control? What are the factors that are modifiable, the behavioral and lifestyle determinants of those downstream risk markers that result in chronic disease? Well, that's where lifestyle medicine really focuses. It focuses, as you can see in the red there in the middle, more on those upstream determinants, not all the way up at the socioeconomic determinants, but in those lifestyle and behavioral determinants. Now, we're not saying you shouldn't have down at that bottom right those medications and surgeries. I'll emphasize it's just providing more options, and also, as we'll talk about in a little bit, lower risk options as well. And it is important, as in any leadership position, that we advocate for the things that we know are important up to the governments, councils, town planners, etc., to ensure that we can optimize the environment and work on those upstream determinants and advocate for them as well as doing the classic medical model downstream risk markers and chronic disease work that we all do day to day, or many of us do. I know there's lots of different professions here today, so not general practitioners alone, but a whole gamut of the MDT, which is great. And if you have a particular perspective on this, as a dietitian, physiotherapist, secondary care, or indeed general practitioner, of course, then you let me know. I'd be very interested to hear it, because we have to all, lifestyle medicine transcends general practice. It goes through all healthcare. So the second principle is those skills to support. This is a lecture in its own right, a fascinating area of medicine, of how we can pull people through, support people through, understand and communicate to people effectively to help them make the changes that often they know that they would like to make. And if they don't, you can help educate them as well and take them on that journey with them, guided by them, to support them into living the life that they want to live. So some of these skills, and there are lots, include health coaching, motivational interviewing, cognitive behavioral therapy techniques, including, and I think this is really, really useful, cognitive behavioral therapy for insomnia, for example, those CBT principles applied to the health behavior change, and then brief interventions as well. So we can talk about that in context a bit later, but there are a number of skills that are useful to acquire to help activate people, to help bring them along their stages of change, perhaps from pre-contemplation to action, which can be really heartening to see. And we know that often if we approach people in the wrong way, that isn't really designed around where they're at, the advice that you can give you can fall on deaf ears, and if anything can be harmful, because it can make them feel like they're underperforming, feel stigmatized, and feel like they're not able to do what they should be doing. But actually, it's not about that. It's not about blaming. It's about supporting and appreciating someone for where they're at. And then the pillars, and I think these are the famous 6 pillars: nutrition, healthy relationships, sleep, harmful substances and avoiding them, investing in your mental health and mind, supporting yourself with your mental health, and physical activity. And of course, these are all intertwined. If you can help improve someone's sleep, you often can improve their likelihood to engage with physical activity and their diet, for example. And thinking about someone as you know, a complicated and complex interaction of all of their lifestyle factors, upstream determinants, etc., and focusing really on what matters to them rather than what is the matter with them, as is the classic approach that I was taught in medical school. Okay, so that's what lifestyle medicine is, its principles and pillars. Well, a bit of background on why do we need it? I think we all understand why we need lifestyle medicine. I think it's pretty obvious that helping support someone's lifestyle and doing it well is necessary, but let's add a bit of weight behind that. Well, the first reason is people want it. So there's a great study, and even if it's not 90% for every population, but it was in this one, it's a high proportion of people want lifestyle medicine support over medicines. And so patients want it. The second reason is it's in the guidelines. And it's in most guidelines that are to do with non-communicable diseases. It's very explicitly put in some, including this type 2 diabetes one from NICE. But reality, when I was at medical school, this is just under 20 years ago now, it was lifestyle medicine whispered. It was then, or lifestyle factors whispered. It was then, and then anyway, let's forget about that. Yeah, give them lifestyle medicine advice. But let's get to the good stuff, the evidence-based stuff. That is medicines and surgery. And actually, all really we're trying to do is put that lifestyle factors and the lifestyle medicine element of it is to really clarify and define it as a specialty, but then apply it to the same level as we apply medicines and surgery. And often you end up not needing medicines and surgery, but if you do, that's absolutely fine as well. Now, here's a pretty shocking statistic. This is in the world. Non-communicable diseases are responsible for over 70% of all deaths worldwide. Taking that to the UK, you can imagine, as a developed country, it's actually much higher. So the majority of deaths are from non-communicable diseases. Now, couple that with the fact that we've just been talking about our principles and pillars. The majority of health outcomes are affected by behaviors, environment, and socioeconomic factors. So that is lifestyle medicine. Now, bearing in mind that actually, if you take all of that, the non-modifiable stuff, the genetics, and the healthcare element of that, being able to access good quality healthcare, we are talking about the modifiable risk factors are the majority of the cause of morbidity and mortality. Now, if we were to know that directly, as I'm sure a lot of you do, it makes sense to have a well-defined and effective medical specialty that is focusing on those things, of course. So a bit of extra weight behind that, most of us live with a key behavioral risk factor. Smoking, diet, physical activity not being as it could as per the CMO's guidelines. And I can go through them in a bit if you'd like. And actually over 60% of us live with 3 or more of those risk factors. So, of course, we should be trying to improve these, have skills in how we can help modify people's behavior and lifestyle. And that specialty overlaps with all medical specialty, or almost all medical specialties, and very much is emphasized in lifestyle medicine. Now, a little touch on health inequality. Again, a really big topic, but one that's important just to reference specifically, I think. Defined by the King's Fund as unavoidable, unfair, so it is unfair, and systematic differences in health between different groups of people. The different groups can be due to their protected characteristics, their socioeconomic status, particular groups like those described there, homelessness, sex workers, gypsy and Roma travellers, and also where they are. We know if you look at health inequality, health outcomes, there is a pretty strong north and south divide. So we must be mindful of health inequality, and I know you all are at all times, and bear it in mind, which is why principle 1, the appreciation of those upstream determinants and what matters to the person, where they're coming from, what their situation, must guide how we interact with them. Everyone knows, I'm sure you've all heard of Core 20+5. This is the way that we as a group are looking to focus within England on health inequalities. That's the most deprived 20%. Those 5 key clinical areas: maternity, severe mental illness, chronic respiratory disease, early cancer diagnosis, and finding that hidden burden of hypertension. And then we've got that plus element, which is local to the ICSs, where they feel that they would benefit most. So that's how it's being impacted on a public health perspective. We should always bear that in mind. And lifestyle medicine, as you can see, speaks strongly to all of those areas. Now, there's the 6 pillars, but the reality is that there are more factors than that. And I just wanted to touch on a couple of areas that I think, and we at the BSLM think, are particularly important. The first is social prescribing. Now, I hope that all of you are, if you're able to, strongly engaged with your local social prescribing services. I was clinical director of a social prescribing group for about 4 or 5 years. I absolutely love social prescribing. I think the way that it can connect people to their community, optimize and identify the resources within the community, and then help the healthcare system appreciate the power of the community is so powerful. And the work that link workers and social prescribers do for people on a day-to-day basis is absolutely astonishing, and I'm very grateful for all of that. I think that can be a real boon to people, and it's often what they need. They don't need a pill. Often they need to be connected to their community, and it can be hugely powerful for people's physical, social, and mental health. Deprescribing. So we learn all the way through med school how to prescribe, and then as you gradually get more experienced, you realize you need to learn how to deprescribe more. Just some statistics to base to really back this up. If you look at that graph, it's very concerning. From 1994 all the way up to 2019, it went from 9.5 average prescriptions per head all the way up to nearly 20. This is very concerning. It is extremely expensive, nearly 20 billion a year. It's nearly 10% of our health budget. Prescriptions have more than doubled, as you can see. It's very expensive per person. That is per person, not even just for adults. And the majority of these are for cardiovascular disease, which, as we all know, has a very significant modifiable element that is to do with lifestyle and behavior. So a really, really important skill is to safely deprescribe. If you ask and help someone to lose weight, and they want to lose weight and they succeed in doing that, we mustn't be harming them with their medicines, as well as their blood pressure inevitably reduces, and as their for example, diabetic medications inevitably reduce. It's also important just to emphasize, I know everyone knows this, but clearly, you know, I need to reflect on this. We all need to reflect on this if we're prescribing. Most of the time, GPs overestimate the benefits of medical interventions, and so do patients. They often overestimate the benefit of interventions and underestimate the harms. So that speaks to the importance of considering the harms and iatrogenesis, but also putting more time and thought into how we can effectively utilize low risk interventions. And nature. I think, you know, it's a lovely sunny day out where I am. I look forward to getting out in it, and the importance of nature cannot be understated. Beautiful day in the south of France where my wife and I went walking. How does that make you feel? Well, it's just a picture on a screen, I appreciate, but you can imagine being there. It feels fresh, it feels open, there's a bit of a breeze, it's a lovely day, there's this sounds and smells of nature. We'll contrast to this to a room that I think we'll all recognize is not quite so pleasant. It doesn't quite give me PTSD, of course, but it does not evoke the same feelings when I think of my old consulting room, the one I used to be in. Not the most pleasant of situations. And this more broadly speaks to the fact that we are often nature deprived, aren't we? Our patients very much often are, and helping support people to engage with and connect to the real world and nature is really important and a part of lifestyle medicine and a good life in general, I think. It also speaks to inequality, just, you know, a slight segue, but we know that if you look at a map, the amount of green space in a neighborhood is associated with the deprivation in a community, i.e. there is less nature, less green in more deprived communities. That then has subsequent knock-on effects of the environment, pollution, and therefore illness, and also the climate and temperature. We know that nature and green spaces and trees, etc., are really good at calming down the average fluctuations of temperatures. If it's a particularly hot day, for example, trees can really help calm that down, lower the temperature, and the subsequent issues that perhaps the elderly people can have with severe mental illness, etc. So let's try and get from here into here every now and then. And I'm not suggesting that we all move to France, but perhaps something to consider. And then, yeah, so those are the pillars of lifestyle medicine as I was going through. Each one of them is a talk in its own right, as I've said before. So if you have a particular question, a myth that you'd like me to bust or that you'd like to ask, or an opinion about some of these, then please do let us know. Ask the question if you want me to go into more detail, perhaps the Physical Activity Chief Medical Officer's guidelines, some detail about sleep or how to optimize sleep, substances and their impact, etc. You just let me know. No problem at all. I'd love to talk in more detail, but we don't really have the specific time for it today. So those are the pillars. And very importantly, how can it be utilized in clinic and beyond? Well, this is an often asked question. And the reality is, as I've emphasized before, what we're looking to do is integrate it into our normal day. And the way that one does that, I'm talking now as a GP or as a secondary care doctor in clinic, but you can do that with most specialties that are interacting on a day-to-day basis with people and patients. The more you understand about lifestyle medicine, the more it integrates with your practice. So that's the first thing to appreciate is if you have an interest in something, you're more likely to consider it and mention it. So the lifestyle medicine core accreditation, educating oneself about these principles, pillars, is a very, very effective way to make it more likely to be implemented into your practice. We know that, and we should believe that the evidence supports that they are lower risk, that they support medicines and surgery if they are a part of your practice. And it's important to always frame it as lifestyle first and medicines or surgeries if required. But often we can prevent people going up that risk ladder and we stay at the lower risk. And regardless, it gives us more options in our toolbox, doesn't it? To be able to approach people how they want. Because if they said, I would rather not have medicines, which is quite common, then having a really effective set of skills and knowledge around their life, how to support their lifestyle, is imperative and necessary. That's what they're requesting. So the general principles are: understand the evidence base, as I've said, understand it's powerful and low risk, look after ourselves. This is a really important part of healthcare and life in general. Many of us are burnt out or near burnout, feeling frustrated with the system. The NHS and practicing medicine and other healthcare specialties in general at the moment is really challenging. You're time pressured. There's a lot of stress at the moment with world events. These things, you know, we have phones, don't we? And we're always on the go. It's very difficult to switch off and calm down. So looking after ourselves to be able to look after other people is extremely important. Having a strong understanding of the psychology of health behavior change. As I've said before, you have to meet someone where they are and take them where they want to go. And we are here to advise them and support them. So if you know what they need to know, but you can't help them do it, there's a mismatch there. Of course, as you all know, communicate effectively and compassionately. What matters to you, not is what is the matter with you. And I know that's teaching you to suck eggs. I'm sure you know better than me just how to speak to someone. And then knowing the available community resources, that is really important. As I was emphasizing with social prescribing, the ability to connect someone to their community. People really are disconnected from their community quite often these days. It's closely associated with ill health, and actually helping support them. And also they will often have skills that they can contribute to the community, can be amazingly powerful. In consult, if you consult, being person-centered, of course, effectively use the time that you have. A common question is, well, how do I have time? Well, the reality is we often have, especially in general practice, longitudinal care. We can see them for hours over decades. In the classic good old days, perhaps you can do that a bit less now, but you can still follow people up, and you should follow them up as per point 5, making sure that if you're putting interventions in and you're helping people with their lifestyle, that you ensure that they can be followed up by yourself or by one of your colleagues. And then assess, don't guess. Use evidence-based tools. It's just as evidence-based as any other medicine. Having high quality sleep questionnaires, mental health questionnaires, physical activity questionnaires, ways of assessing their diet, etc. It's really important. This isn't woo, this is evidence-based. Just to mention group consults, I hope some of you have done them and are doing group consults. I did group consults for about 3 or 4 years around lifestyle medicine factors, and it was fantastic. You really do feel like you have to become a Jedi with your Jedi means very good with your consultation skills, and I really enjoyed them. It's often more effective than consulting on an individual level. To go through it in a little bit of detail, if you don't do them already, I would really I would really recommend you consider them. So it's up to 15 people. They have a similar condition and they've been selected. They want to do it. We shouldn't make people do group consults if they want to consult individually. They have information about it. They've consented. Medical confidentiality is being considered. We have the prerequisite tests, etc., that they need. The facilitator introduced the session, make sure it's the right people, goes through the plan, get some questions for the clinician, have a little break. Then the clinician comes in, consults with everyone individually. And for the people who consult here, which is most of you, how many times have you absolutely nailed an explanation for a topic? I know that I do sometimes really, really explain things really well. I also know that sometimes I don't explain them as well as I could have done. And there's lots of reasons why that's the case. But the great thing about group consults is you can take the time to get it right for that person, and you don't have to repeat yourself. You know, so in clinic, you'll often repeat yourself 5 times a day at least, plus. And the reality is, not every single one of those times would have been as good as maybe the best time you did it. Whereas in group consults, you can make sure you really nail that piece, and then everyone heard it in the room, so you didn't have to repeat it. And it can be really, really useful. They also provide knowledge themselves. It's also a very effective way of having people appreciate that they're not alone in their experience. So, for example, with chronic pain, it can be so useful because people isolate themselves and they feel like it's insurmountable with chronic pain, don't they? And actually, that group accountability, support, and creating a peer group, a network, and a shared experience can be so powerful for behavior change. You then have a facilitator support. They create their goal settings based off what you've discussed. You leave. They signpost them to support, and they do feedback as well. So you can consult with, I've consulted with 12 people in an hour, maybe an hour 10. It can be really effective to get through people, and every single one of them heard every facet of what you were trying to explain to the group, but on an individual level, which can make it very, very effective. Because in my experience, the first 5 asked the questions that the rest wanted to know, and then there's little tweaks for the next bit. So it could be really, really useful, and I would highly suggest you consider them. So that's what we've talked about, a bit about lifestyle medicine, a little bit of a background. The background is that people want it, it's effective, it's safe, and the guidelines say that it would be useful. We've talked about health inequalities, how we can integrate it into our practice. Again, it is a bit of a flight through, but if you have any specific questions and would like us to go into a bit more detail, I would love to. And yeah, just to emphasize, if you want to join, if you do SBK 50, you get a year off your first, 50% off your first year. Thank you very much. If you want any more detail, some of the evidence base behind it, then you just please let us know. We have evidence base falling out of our ears, don't we, Fraser? So
Absolutely.
I'd love to hear it.
Yeah, we have a huge amount of Sorry, Alex. Thank you for that. We have a huge amount of information on our website for members and non-members, actually. So please do check it out. Some great questions coming through, Alex. So I'm going to take the first one, actually, because I think it's a very quick answer. And that is BSLM core accreditation suitable for nurses? Absolutely, it is. Actually, nurses do most of the work, don't they? I'll duck now that I've said that, but yes, they do. So what the course does specifically is allow the learner to tailor the learning experience to your own expertise and your own area of interests. So it's absolutely geared up for nurses to talk about actually the practices that are already developed, as well as practices that could be developed on the basis of the learning. So yes, absolutely is a quick answer to that one. Alex, first question on sleep. This is an interesting one, and it's actually one I think we've heard before. How do you go about advising somebody who's struggling with sleep if they're working unsociable shift patterns? So are you still recommending the kind of the 6 to 8 hours a day, or does the shift pattern actually impact on that advice?
Yeah, that's a great question, and one that many of us will have considered over the years. One I very much have, as I drag myself home as the sun's coming up, thinking, my goodness, how am I going to get to sleep? It feels very much like everyone else is waking up. So that is a complicated question because it depends on the shift pattern and the person. As is the way of lifestyle medicine, we have to think about the person. But the general principles are, one should always remember the inputs and the factors that affect sleep. So light, your environment, this is sleep hygiene, as well as some as well as some of the behavioral stuff. But the big answer to that is the inputs. So when you're eating, try and keep when you eat the same as when you would like to be sleeping. So keep your eating pattern on the same shift as when you would want your day to be, and then you sleep at night. So try not to eat during the night. And also your light. So optimize your light, try and minimize light impact just before you're going to sleep. Wear eye masks, make sure your environment is cool, about 18, 19 degrees, and quiet. So individualized advice for the person in front of me, I would go into more detail. You can talk about the substances that you have, the way that one can optimize one's particular shift pattern, but the principles are the inputs that affect one's sleep, which is in general light and food.
Great, thanks, Alex. A couple of really interesting questions about health inequalities, actually, and you talked about being aware of health inequalities, but in practical terms, what can our delegates do to advise people or to become involved and influence the upstream determinants of health, which of course is a massive challenge? So what can we as lifestyle medicine practitioners do?
Yeah, great question. So on an individual level, we appreciate that it can be very difficult to impact the upstream determinants. What one does is appreciate the upstream determinants. Now, on an individual level in consult, talking as a GP, but I know that other specialties have similar access to being able to advocate for people. You can link them to community resources that take into account their financial situation, their housing situation, and give them advice and support statutorily, and also to voluntary care sector groups that can support them and consider those upstream determinants. So a classic, for example, would be someone has mold in their house. You can link them to the available supporting resources that allow them to change to advocate for themselves and have that being impacted, or debt advice, for example, those kind of things. That's on an individual level. Where actually one can make change to the upstream determinants of health and disease is not on an individual level, and it's not directly through lifestyle medicine. It is through the advocacy for these factors and punching up to the people that do make the decisions, the policymakers, and the people with the purse strings. And that then requires you to collaborate with like-minded individuals and organizations to create consensus statements and be politically aware, and to integrate with those people and be in the tent, as we often say in BSLM, to be able to influence and advocate for the specialty, but also the people that you look after and support and advocate for when those discussions are happening in those rooms. So yeah, it's about being there and shouting about what is important and joining up with people who do the same.
Great, thank you. There's a question about core accreditation and questionnaire, which I'll answer quickly. At what academic level is core accreditation? It's postgraduate, and it's based at postgraduate certificate level. And actually, it's going to become the first part of a master's degree, which BSLM are developing with a partner university. So if you undertake the core accreditation, you automatically get credits towards your master's if you go down that route. So very much a postgraduate qualification. And there's a question very quickly there about lifestyle medicine questionnaires. Please use the link that's in the presentation to go to the BSLM website. There are a huge number of supporting documents to help people practice lifestyle medicine, and lifestyle medicine questionnaires is one of those. So please do go to that. Another question that crops up all the time, Alex. It sounds like lifestyle medicine interventions are much more time intensive, and given the time pressures that general practitioners in particular face, but other healthcare professionals, how realistic is it to have those lifestyle medicine conversations with patients?
Yeah, that's a great question, and one that we think about a lot. So there's a few facets to that. I agree that we don't have enough time to do the job that we would love to do. But I actually disagree with the principle, and I think it's a little bit reductive, personally, that we don't have the time. In my experience, if you learn about lifestyle medicine, or indeed any area, women's health, child health, any area whatsoever, you start to see it, and you are able to have those conversations far more easily. So if you think about it on a clinician's level, or at the level of one clinician, if you are highly motivated and educated towards lifestyle medicine and these principles, if you think about every 10-minute consultation, every 3-hour, 4-hour session, every time you're seeing someone, 20, 25 people, maybe more, in fact, definitely more, some of the clinics I've done, the amount of lifestyle medicine and principles would have infused through every single one of those consults. And actually, if you were to add up the impact of that, it would be quite significant. So that's the first thing. Is I think if we think about it in these discrete 10-minute blocks where we don't have any time, I think that's a slight false consideration. Although I do very much appreciate the time pressures. The second is there are effective techniques that are time efficient. So we're talking about those questionnaires where you can send them out to the person beforehand, afterhand. We can see them again and go through them. And ultimately, the question we should ask ourselves is, what do people want? And actually, people want this. Yeah, of course, there's a number of people that just want a pill, in inverted commas, and you have to approach them differently through the psychology of health behavior change and help them move towards appreciating the importance of that. And for some people, it's just not important to them because they're upstream determinants or because of their experience. That's also fine, right? We're not forcing it on them. But the reality is People do want this, and therefore we should be serving the person in front of us with an understanding of that. And I do believe that we can meet our QoF requirements, we can meet our extended needs, and we can meet our day-to-day requirements for running a GP practice, whilst also infusing lifestyle medicine principles to add to your toolbox to make you even more effective. It also helps you, right? I have found it very helpful for me. It's protective against burnout. It's helped me feel more flexible and less stuck having to consult like that. So yeah, I think it is possible.
Great, thank you. Yeah, interesting question here, which certainly wouldn't have come up 10 years ago. Do you ever signpost patients to podcasts? And then the question goes on to talk about kind of trusted sources, such as Dr. Chatterjee's podcast. But there's a heck of a lot of noise out there. So do you signpost to podcasts, and what are the risks of signing to podcasts, I guess?
Yeah, it's a great question. The honest answer is yes, I do. It very much depends on the person. I tend to listen to podcasts that are, this is just me, either completely non-medical, like the rest of politics type stuff, or relatively technical. So, nutrition podcasts, Sigma Nutrition, for example, which is quite high level. You wouldn't signpost many patients to that. But in terms of trusted resources, yeah, we do have a list on the BSLM website. Rongan's is on there. We've got our own podcast. There are a number of podcasts out there that are trustworthy, mainstream, evidence-based, just like lifestyle medicine, not on the fringes, not with zealots, etc. All of these things. And actually, yeah, they can be a great source of information. And people often bring them to us. And then we do have a bit of a need to be able to critique that information and tell them whether it's useful or not for them. So yeah, I try to keep engaged with the space, but you're right. We should be careful that it's pretty mainstream and we're not talking about Joe Rogan, for example.
Great. Do you feel that the current movement at a government level towards community and even towards neighborhood is in line with lifestyle medicine? And do you think that there's an opportunity there to expand the scope of lifestyle medicine at the local level?
Yeah, great question. And the answer is yes, this is something that was on our agenda and has been for quite some time, to be honest. So it was a pleasant surprise to see slightly unpleasant, but it was already corroborating what we knew and what many of us knew, which is that we did need to move toward, from treatment to prevention and from analog to digital, and from hospitals to communities. We, especially GPs, have known that for a very long time, as many of us have. So the opportunity there, I think, is pushed through social prescribing, group consulting, primary care, multidisciplinary working with lifestyle medicine principles. I completely agree. And yes, absolutely, engaging with people on their terms, going and talking in their communities, engaging them with their health and not having them come to us in general practice. In the classic sense, so we can have teams that can do it. You can integrate with schools, you can collaborate with councils, all of these things that, yes, we are doing to spread the message of lifestyle medicine and have it integrated with normal life, have people in schools appreciate lifestyle medicine, put it into curricula in medical schools, in other healthcare professionals, university courses, putting it all the way through from amateur to professional, from education to PhD and above, all the way through our society.
Yeah, it's interesting, isn't it? This comes around every so often because I remember 25 years ago working in Scotland in adult social care and having these conversations around care in the community and getting people out of hospital and treating people in neighborhoods and so on and so on. So it's back on the agenda again. Let's hope it's a little bit more successful this time. Again, a common question that we get, Alex, good food is more expensive to buy than ultra-processed foods. It's partly obviously related to inequalities, but also behavioral change. How do you go about having that conversation with somebody who is struggling financially, struggling to feed the family around healthy nutrition, balanced diets?
Yeah, a wonderful and very pertinent question. Thank you to whoever asked that. It's a great question and one that we are tackling every day if we're talking about this. So yes, ultra processed foods is less expensive per calorie. It is actually not more expensive per nutritional value. And this is something to consider, that people are often malnutrition but over caloric consumption. So that's something to consider. The reality is you meet someone where they are, you see what their access is, local food banks, markets, and you ultimately can support them with education. So one of the most effective things that interventions that I have engaged with, supported and spread was cooking programs. It was integrated with schools, and children and families came in and relearnt. The children learnt, and often the parents either relearnt or learnt how to cook nutritious meals that were affordable, and they were affordable. Principles around actually not being afraid of canned foods, dried goods that can have good quality nutrition within them, beans, legumes, pulses, all these kind of things that can help people with their fiber. We know that people are chronically underfibered, and their protein intake that is not necessarily that expensive on a budget. And also thinking positively, so not looking to say that food is bad, but to say these foods are supportive and healthy for you, and adding to their diet, not taking away from their diet. Ultimately, it is very, very challenging. And we know that there are more, as an indicator of deprivation, the chicken shop to coffee shop ratio is a real positive correlation. Unfortunately, their environment, their food environment, which is the biggest single factor that influences what people eat, is very, very difficult. And I would just like to shout out to Bite Back, the fantastic organization that are looking to change the narrative around, in particular, the health and food environment for children. If you've not heard of Bite Back, then we can put it in the chat actually, then please do look them up. They're fantastic. But the reality is it needs a joined up approach from education all the way up to advocacy at a policy level to make a change to their environment, but also empower the person in front of you with some of those skills to navigate that really challenging food environment. And it is not easy. It is not easy.
No, absolutely. Well, time for one very quick final question, Alex. We literally have 90 seconds left.
Okay.
So very quickly, how often do you, as a lifestyle medicine practitioner, refer on to dietitians, and I guess by association, other specialists within the healthcare system? So really talking about whether or not this is a multidisciplinary movement or not.
Yeah, great. So regularly as I'm able to and can get away with, if I'm honest, because multidisciplinary team working is everything for healthcare. None of us know everything. And actually, the people that really make a difference to people's lives, in my experience, are the social prescribers, the link workers, nutritionists, dietitians, health coaches, those kind of people that can make an incredible impact. And it's because of the time that they can spend and the skills that they have. Weird direction changes. They're catchers and carriers, aren't they? And I find that wonderful. So yeah, regularly. The reality is that in some situations it's difficult, isn't it? Because we're limited by criteria and guidelines. But yeah, if you can get more people involved, the evidence suggests that the greater the intensity and the longer the duration, the greater the change. So yeah, if you can do.
Perfect timing to the second, Alex. Thank you. So that wraps up the presentation around lifestyle medicine from BSLM. So thank you so much for listening, and I really hope you enjoyed it.